What if one supplement could make your entire immune system smarter? Not stronger, in an aggressive way, smarter. That's exactly what BWH 85 beta-glucan from BWH Labs does. It works with your immune system, helping it recognize threats, respond effectively, and protect you the way nature intended. BWH Labs has spent over 25 years perfecting the purest, most biologically active beta-glucan on the market, an 85% pure formula that's been tested against 200 competitors and named the most effective immune modulator in peer-reviewed research. The science speaks for itself, just one ingredient, one focus. Unmatched results. Doctors and integrative health practitioners trust BWH 85 beta-glucan, and so do I. It's available in 100 milligrams for daily support or 500 milligrams for maximum immune defense. It's only available through health practitioners, but as an intelligent medicine listener, it's available to you through my full script dispensary. Just go to drhoffman.com/BWH for more information and to order. That's drhoffman.com/BWH. Because a smarter immune system starts with one smart choice. Welcome to today's Intelligent Medicine Podcast. I'm your host, Dr. Ronald Hoffman. I think today's podcast is an essential guide to those of you who may be at some point considering being in the hospital. If you think that you are exempt from that, well, it's likely you are not, because at some point in our lives, we're always forced by the exigencies of fate and health to end up in a hospital. And even if it's not you, it may be a relative, it may be a parent, a sibling, a child who's in the hospital. We're going to talk about, I think, an essential accoutrement to your hospital stay. It's a great book by today's guest, Dr. Julie Siemers. She's author of Surviving Your Hospital Stay, a nurse educator's guide to staying safe and living to tell about it. And it's a great book. It covers a lot of ground. And today in our discussion, we're going to cover a lot of ground. Dr. Julie Siemers, who's often referred to as simply Dr. Julie, is an RN. She also has a doctorate as a nurse practitioner, a DNP. We'll ask a little bit about some of these nursing credentials because it's kind of a hierarchical series of credentials, starting at LPN, going via RN and nurse practitioner to the ultimate credential where you get a doctorate, as did Dr. Julie. She's a patient safety consultant and an advocate for patient safety. She is an educator and founder of LifeBeat Solutions, where she consults with hospitals and medical practices to make them safer. And, of course, author of the best-selling book, Surviving Your Hospital Stay, and Nurse Educator's Guide to Staying Safe and Living to Tell About It. So without further ado, here's Dr. Julie. Dr. Julie, it's a pleasure having you here on Intelligent Medicine. Thanks for joining us.
Thank you. I appreciate you having me on as a guest to talk to your audience.
Indeed, indeed. Well, one of the points you make in the book is that hospitals can be dangerous places. Please explain.
Yes, well, medical error is the third leading cause of death, and it has been for quite a while. And a lot of that does occur in the hospital. And there's various ways that happens, which is why I wrote the book to help patients and their families kind of understand the scary healthcare system. And I say scary because it's complex. It has really a different kind of language than we understand as lay people. And it really is, you need a roadmap to navigate to stay safe in that hospital setting because there are so many things that can happen. And I want to preface it by saying there's no practitioner that intends on harming a patient, whether it's a doctor, a nurse, a radiologist, a phlebotomist, but it does occur. And just being informed and educated is your best defense in really staying safe.
So what prompted you to come forward on this? Because in a way, just like, in any profession, the police, among the medical doctors, there's kind of the so-called thin blue line, which tends to downplay or obscure the dangers and cover up mistakes. And you're right out there in front leading the charge to point out the hazards.
Well, as you first said when you opened, that we're all going to be a patient or have a family member who is a patient or a loved one someday. And I really believe that we just need to be aware is the first, we learn that in nursing school and medicine is the assessment piece, is really understanding the lay of the land. When I started teaching about 15 years ago, and I realized, and I was using case studies to teach this nursing students, and these case studies were about what can happen if the nurse doesn't make a good decision or recognize that a patient is becoming unstable. And in that research, all of these stories that I found were true stories of harm that happened to patients. And when I started peeling back the layers, I'd already been a nurse 30 years before I started researching. And that's when it was just really shocking to me to be in the system and not really know or understand the system from that perspective. And I just really felt like it was my professional and personal obligation to share what I had learned and share what I knew to help people.
Indeed. Well, in the book, there are scary examples of things going awry. And, it's just like, when the Federal Aviation Administration, the FAA, goes to a crash site and does an analysis. In a way, I would appreciate more if there was less of a blame game being played, with malpractice and litigation, and then sometimes people hiding stuff because they're afraid of revealing that a mistake was made. Let's look at our mistakes and analyze them as you have in the book. Can you give us some examples?
Yeah, you bring up a really good point. The National Transportation Safety Board and the FAA are all about understanding what happened so it won't happen again. And unfortunately, we haven't crossed over in healthcare to adopt that same attitude, that same responsibility, that same transparency. And that's why these mistakes keep happening across, different hospitals across the nation, even across the world, in that we're not transparent and we do sweep it under the rug. And again, it's because of the fear of litigation, as we know. But, all of these examples are harm that occurs at a systems level.
Mm-hmm.
Yes, it is an individual that makes a mistake, such as a medication error,
Mm-hmm.
but what is it in the system that we didn't fix to prevent that error from being able to happen or occur,
And
such
usually
as
it's not a one-off. It's a
right,
cascade of errors. In other words,
it
it's
is.
a situation that leads to a perilous setup, and then things go awry, and there's a cascade of problems. And then maybe there's people are not realizing what's going on. They're ignorant, or they're
Right.
exhausted, or they're overworked, or not giving proper attention, and then a tragedy ensues.
Right. And we have to understand that humans are in the system and are making decisions and doing things, acts of omission or acts of commission. And that's where we have to anticipate that a mistake will happen. So then we have to put those guardrails in place.
Okay, so
And
so
that's where I think we're at.
so you're focused on the nursing profession. So what critical role do nurses have in preventing mistakes? Because generally they are not the ones who are administering medication. Well, they follow orders to administer medication, but most are not autonomously credentialed to order medications,
Right.
and they're not the ones performing the surgery. They're not the ones who are administering the radiation treatment. So are they critical intermediaries between the actual decision makers and the patients, like a buffer between them?
Excellent question. Because in most American hospitals, nurses are at the bedside 12 hours with the patient. Most acute care settings have 12-hour shifts. And they're the eyes and the ears, really, to say to the physician, when you have a patient, let's just say who had surgery, And maybe they're a little volume depleted because they didn't get quite enough, maybe the surgery went a little bit longer. And the nurse is responsible to recognize those signs, such as increased heart rate, increased respiratory rate, a dip in the blood pressure. And if we don't get ahead of those, the patient could go into hypovolemic shock. So it's noticing the signs and the symptoms of what is called failure to rescue in the literature, where there's neurological changes, there's vital sign changes, there's, the fluid volume. Maybe the patient hasn't urinated in 6 hours, and that'll give us another clue as to what is going on physiologically. And that research out there, the literature tells us that these signs and symptoms of beginning to become clinically unstable happen 6 to 24 hours at least before an unplanned cardiac arrest.
So this is clinical information, but some of what can occur has to do with the culture of a hospital or a medical care facility, the doctor-nurse relationship, which is sometimes, from my personal experience, can be frosty. For example,
Yes.
I, as a novice physician, fresh out of medical school, hit the wards of a busy university hospital in my 20s, very green, imbued with, scientific theory, but bereft of experience. And suddenly I was working with experienced nurses who'd been in the hospital for decades, and they kind of took a dim view of me very often. Similarly, doctors can be imperious. They can say, "What do you know? You're just a nurse. We
Right.
have the expertise, we've gone to medical school," and that can foster a culture of mistrust and even antagonism, right? But that's
Yes.
bad for the patient ultimately.
It truly is. The Joint Commission has come out year after year saying that patient harm is 70% of the patient harm events that occur are due to communication breakdown.
Mm-hmm.
And that's either between the healthcare team themselves, as you said, doctors and nurses, or doctor to doctor, nurse to nurse, even, or the healthcare team and the patient's family. That
Ah,
communication is really a huge deal, which is why in my TEDx talk that I gave a couple months ago, I focused on how families and how healthcare providers can really bridge that gap and have that open communication that is going to foster, oh, your mom doesn't usually act like that. This is new. Let's see what's going on.
mm-hmm.
Really having that two-way communication is so essential.
So this actually calls for, and I think that's one of the themes of your book. It's not geared necessarily to nursing professionals. It's geared to the general public surviving your hospital stay. So that argues for an active patient, not a passive patient. A lot of people go in the hospital, they're just bewildered and obedient and, follow orders, and they can actually have some of the worst outcomes than patients who are a little uppity or a little challenging, or perhaps have a family member who can advocate for them.
I think the best thing you can do for yourself, even before you go to the hospital. So this is all proactive.
Mm-hmm.
Understand your disease process, understand your medications, and know your body. Those are the three best things that you can do. And then when you're in the situation that you're in an acute care setting like the hospital, you can ask those questions. Oh, what's that pill that you're giving me? Again, going back to the nurse, oh, well, it's your blood pressure medicine. Well, that doesn't look like the one I usually take. And
Mm-hmm.
asking those questions to, oh, well, what does the one that you take look like? Or I already take a blood thinner. Am I supposed to go home from the hospital with another blood thinner? Let's just say they had hip surgery,
Mm-hmm.
but they've got the history of atrial fibrillation. So that happened to one of the patients I was taking care of with students a few years ago. They ended up coming in the hospital with bleeding at their surgical site at the knee, because they were taking two blood thinners that they really didn't need.
Wow,
And
double
so
trouble. Yeah.
asking those questions is so essential.
So how do you do that diplomatically as a patient? Because frankly, can come off as kind of annoying when patients are bombarded. Doctors are busy, nurses are rushing around, they have a lot of responsibilities, and the patient, the family comes in. It's like, oy vey, now I got to talk to these people. they're peppering me with questions. Sometimes they're angry. It's a turnoff. I don't want to talk to them. Let me hide in the orderly room.
Yes. So one of the tools I share with patients and their families is the three P's: be present, be polite, and be persistent. So if we come from the perspective of curiosity, like, I'm really wondering why I'm receiving this antibiotic when I think it may be, you've done your research, because you have an allergy, it may be close to the one I'm allergic to. Can you help me
Mhm.
understand, using that perspective? And yes, sometimes patients and their families are angry. They've been made to wait. They don't understand. They're not feeling good. Maybe they've just got the diagnosis, they've got cancer,
Mhm.
and that anxiety is really high. And so it's hard to be polite sometimes. But I always teach my nursing students that, hey, those patients in the bed and those family members are having a way worse day than you are. And it's your professional responsibility to be polite and to be kind.
Okay, folks, at this point, let's pause and allow one of our sponsors an opportunity to share an important message with you. So here goes. Listen up. You know that feeling. You're exhausted, but your brain just won't quit. You're staring at the ceiling, watching the clock, dreading the morning. Here's something that actually helps. It's called Kyolic Specialty Series Sleep Mushrooms Plus. And it's unlike anything you've tried before. This isn't some chemical sleep aid that leaves you foggy and dragging the next day. This is a clean botanical formula built around certified organic reishi mushrooms grown on real farms, not in a lab, combined with valerian root to help you fall asleep faster and stay asleep longer, L-theanine to quiet that racing mind, and Kyolic aged garlic extract, one of the most trusted wellness ingredients available for circulation and stress support. It's vegan, non-GMO, no gluten, no dairy, no artificial anything. Just 2 capsules, 2 hours before bed, and you wake up actually rested, not groggy, not out of it, just refreshed. Kyolic Sleep Mushrooms Plus from Wakanaga. Learn more about this and the entire Kyolic Mushrooms Plus line at kyolic.com. That's KYOLIC.com. Look for Kyolic at natural health stores nationwide and online. Thanks very much for listening, and thanks for supporting our sponsors. They, of course, are what make intelligent medicine a continuing free resource to you. And now back to today's guest, Dr. Julie Siemers. So how about this notion of when you go to the hospital, always have an advocate? So it could be a family member. See, I was always called upon to do that for my family members because I'm a medical doctor. So even if I wasn't on the case, I could go in, I could speak the lingo, I could talk to the doctors, I could interact with the nurses based on my experience politely, but sometimes, asking questions. It's important to have someone like that because when you're the patient, and I would hope that would be the case for me, because when you're sick, you're not in the most resourceful space to advocate for yourself.
Exactly. The other thing I would suggest to all patients or all people before you become a patient is check out the hospitals in your area. There's a website that is a nonprofit organization, and it's called hospitalsafetygrade.org. And you can go on there and see if your hospital is rated for safety an A, B, C, D, or F.
Wow.
There's 22 categories and subcategories that are around surgical outcomes, for instance, blood clots after surgery, respiratory distress such as pneumonia after surgery, the different kinds of infection rates at the hospital, whether it's MRSA or Clostridium, C. difficile. And you can see there's also a category for leadership and doctors and nurses being able to communicate together and work on, patient safety areas. And so you can go to an A-rated hospital and get better care. Your outcomes are going to be much better than if you go to a D or an F-rated hospital. I'd start there.
That kind of makes sense because even when I buy a T-shirt, I look at the reviews, and it's a lot less consequential than going to a hospital for an emergency or an elective procedure, right? So you want to do that. Now here's a fundamental question: is community hospitals local to your neighborhood? Because let's say you live in a community in suburban New Jersey. And you need a procedure. and the place that does the that has the center of excellence is located in New York City. But you, for the convenience of it, and for the fact that the nurses in the hospital in your small community may know you, they're your neighbors. Which is better? Because you might get physicians of excellence, specialists who can deal with your condition because they have a wonderful reputation as part of a university medical center where they do research. But the care that you're going to get at the bedside may be kind of arbitrary. There may be a disconnect between the medical expertise and the nursing care. So this is a fundamental question.
Yeah, again, I think it's do your research before you need to get the emergency care or if you're going to have surgery. And then I would ask those questions. When you look up the hospital and you can see specifically in all of those 22 categories, red, yellow, or green, let's just say you've got the best surgeon
Mm-hmm.
in the world, but this hospital has really poor
Yes.
outcomes for postoperative blood clots, then you're armed to ask that surgeon, how are you going to help me not get a blood clot? Because we know there's preventative measures. Do you follow evidence-based practice? And are you going to write an order for, me to have those compression stockings that's going to prevent that blood clot? So again, it's asking in a collaborative way, but from an informed and an educated perspective.
So let me ask a little bit about nursing credentials, because when you go to the hospital, there's like a flurry of people, sometimes with different uniforms. You don't know who you're talking to. It's an alphabet soup. There's LPNs, I think at the basic level. Then there's RNs, of which you were, and then you took advanced studies. Did you go through the process of becoming a nurse practitioner or
I
an
did
NP before you?
That's different.
Okay, so there's the NPs,
Correct.
nurse practitioners, and then you're top of the heap, academic nursing, a doctorate, and a DNP. I guess it's a
Nursing
doctorate in
practice.
nursing
Nursing practice.
practice. So those are few and far between. But let's talk about the different tiers and what their different responsibilities are, and how much autonomy they have. Because for some, it's just a matter of, they're low on the totem pole. They can't make a lot of decisions. And some have more
Yeah,
purview.
in the hospital setting. So I was an LPN myself for 10 years, and there was only three things that I could not do. And this was in Spokane, Washington. I could not take a verbal order from a doctor.
Okay.
I could not hang blood components for a transfusion, and I could not push IV medications. Those are the only three things I couldn't do.
Okay.
And so I wasn't really inspired
Okay.
to go back to school and get my RN because I had kids and whatever. And then when I wanted to do more in the profession and not get away from the bedside, but do more in leadership, that's when I went back and got my associate's degree and then my bachelor's degree and then my master's degree because I wanted to teach in the classroom, not just in clinicals. And then my doctorate of nursing practice because I wanted to take all my education and experience and apply it to the bedside. That's the difference in a PhD in nursing does research and a doctorate of nursing practice applies the research to the patient at the bedside.
So with this stretched medical system where we really have doctor shortages, I see more of the drug addicts. It used to be, ask your doctor about this. Now it's like, ask your health practitioner about this. Ask your health professional about this. So, and a lot of people in this healthcare system, at least initially or between visits, they may not see an MD. An MD may be in charge of the practice or supervising the practice or a collaboration of MDs, but you may be seeing an NP or a PA. What are those? What are the distinctions? Because NPs have a lot of autonomy. They can see patients individually. They can they can prescribe medications. They could do a lot of stuff. PAs similarly.
So they're
What's the
both
distinction?
mid-level practitioners. They both can write prescriptions. The PA, physician assistant, has to work under a medical doctor's license. A nurse practitioner, depending on the state, can hang their own shingle and yes, write their own prescriptions. Not in all states because they're still under the board of nursing.
State by state, yeah.
But yes, they can write prescriptions. They don't necessarily have a doctorate unless they've gone back to school for that specifically. A nurse practitioner is a postmaster's certification.
Okay. So, more and more we're going to see that. One of the trends in medicine, and I guess it's just economy of scale, is that nursing personnel sometimes supervise patients remotely. There are services where, especially if you're in in the boonies, maybe you're somewhere in Alaska or something, and, they're really stretched for medical personnel. You might have a nurse or a nurse practitioner, perhaps a nurse practitioner at a higher level, who is monitoring people remotely, like on a Zoom call, right? We're looking at all their parameters. So what do you think of that? Is that a setup for problems or, a modern
I think it's
necessity?
definitely of modern necessity. And you're right, we don't have enough practitioners, doctors, or even mid-level practitioners and nurses. I mean, we're a shortage across the country, but I think it's great in that gives some experienced practitioner to look at the vital signs, for example. Hmm. But there are so many things that are the physical assessment piece that can't go
Yeah.
along with that you're missing, that can give you,
Right. Like an
yeah,
intuitive
yeah,
connection to the patient, that
yeah.
occurs at the bedside.
If
Yeah.
they're tachycardic, if their heart rate's fast or their blood pressure's low, is their skin warm and dry and pink? Some of that you may be able to tell.
Hmm.
But there's those other, do they have, pedal edema? Do they have, what else is going
Yeah.
on? What are their breath sounds? If they got some crackle, their breathing difficulty is increasing.
Well, there's no substitute for human intuition. And sometimes, you could just look at someone and say, I've seen this person day to day. They just don't look right today. And, you can look at their vitals and, that certainly is a surrogate marker for distress. You've got to look at the vitals. But the impression of the bedside, and I think that's what a skilled nurse
Hmm.
brings to medical practice. And doctors are rushing around, maybe they've gone back into the operating room or, they're running around doing consults. And a call from a nurse saying, hey, I think this patient needs a little more attention. I just have a bad feeling about this. And that I think is a useful
You're right.
intervention.
And sometimes you can't put your finger on it. You just, like you said, they
Yep.
just don't look right, but you can't actually give any hard and fast data yet. But in my experience
Hmm.
in critical care, it does show itself, usually not too long after you've got this sense of something's not right. So those patients bear
Indeed.
surveillance and vigilance in that surveillance.
Okay. All right. We're going to pause here because we divide our podcast in two parts. I got lots more questions. Plus, I want to hear some examples of medical mayhem that you can avoid if you follow some of the advice in Dr. Julie Seymour's book, Surviving Your Hospital Stay, a Nurse Educator's Guide to Staying Safe and Living to Tell About It. We'll be back with more of today's Intelligent Medicine podcast. I'm Dr. Ronald Hoffman, and this is Intelligent Medicine.